One of the exciting things about being here at the meeting here in Munich is hearing how important MRD is becoming to clinical investigators. And the trials that have been proposed very often have MRD involved. Having said that, there's been some great clinical trials already performed with samples stored, but not the kind of sample set we can really test and really get an answer to that. So an example of that would be the BMT-CTN trial 0901, which was a randomized phase 3 trial, really trying to answer the question of conditioning intensity in allogeneic transplant in patients in remission from AML. That's the perfect trial to work out the impact of MRD in allo transplant, which is the question we're all asking. Unfortunately, there's no diagnostic information on those patients available. The samples were stored from peripheral blood in a pellet in a way that makes flow cytometry impossible. It also makes PCR impossible. There's no way to extract RNA from the samples. So really it's forced us to push the technology in DNA sequencing really to the next level to try and use those samples to answer that question. The great problem is next generation sequencing with DNA can be as sensitive as you'd like it to be. If you put in enough material and you run the machine, you can make it as sensitive as you like. The real problem with next generation sequencing is specificity and the false positives. And so part of the reason with the work we're presenting here and some other work we've done with other methodologies is really trying to solve that problem. Can we reliably call variants in a sample where we have no prior information on what variants that patient has? To predict, to see whether they have a variant still present in the remission sample. I think that's got implications in the short term over the next year. We hope to be able to answer the question with 0901 and conditioning intensity. But I think even beyond that, we know that AML is a heterogeneous disease. We know it's oligoclonal. We know that clones come and go. And so our current approach of using next generation sequencing based on variants in the diagnostic sample may not be enough to track the variant which you don't know about, which is coming up and is going to be responsible for relapse. So if we can solve this technical problem, I think it's something that can be used going forward in NGS monitoring for AML MRD generally.